Good afternoon, everybody, and welcome to our third Leadership RCN Lunch and Learn webinar. And today we are going to be talking about crisis to business as usual, whatever business as usual is. And I'm absolutely delighted that we've got Commodore Ali Hofman with us this afternoon, who is going to tell us how we do that. I'm sure she's now saying, am I really? But I am so delighted that Commodore Hofman can be with us because she is a career military nurse, joined the Navy in 1989, where she qualified as a registered nurse in 1992 and further qualified as a clinical care specialist in 1997. Ali has had extensive operational experience in clinical and healthcare leadership and management roles, completing operational tours to Kosovo, Iraq and Afghanistan, and also has NHS experience with clinical postings in the UK. Her CV is just amazing, so I'm just going to pull out some of the things that she's done. In that she's been promoted through the ranks, and she is also part of the alumni of the Joint Command and Staff College, the Windsor Leadership Programme and the Defence Strategic Leadership Programme. She was awarded the Associate Royal Red Cross and Royal Red Cross in the New Year's Honours Lists in 2007 and Operational Honours List September 2009 respectively. In addition to her military responsibilities, she has recently been appointed as a trustee of the Florence Nightingale Museum. Her role at the moment is her head Defence Medical Services Regulator, so her qualifications for talking about crisis to business as usual is absolutely amazing. Ali, welcome.
Thank you, Denise.
And I know you're going to do a presentation and then you're going to answer some questions for us. And I know that there's many people on today who want to ask you lots of questions, and you're with us until 10 to 2. So Ali, thank you so much for your time, and over to you.
Thank you, Denise. Firstly, I was delighted to ask to speak to you all today at the Lunchtime Learn session, and thank you very much, Denise, for firstly asking me to come and speak today and that very kind introduction. What I've been asked to cover today is some thoughts on the leadership challenges that you face as we come out of the unprecedented challenge and rapid change required due to the COVID pandemic. As Denise said, my current role is as the head of the Defence Medical Services Regulator. So just to understand what that is Defence have a disapplication to the Health and Social Care Act 2008 regulated activities, regulations 2014. So me and my team on behalf of Defence is responsible for the regulation, assurance and enforcement of healthcare delivered by the Defence Medical Services to service personnel and entitled civilians. And that includes all operational and overseas healthcare facilities, as well as primary, dental, defence, community mental health and rehab care in the UK. Like the NHS, the COVID-19 pandemic has presented a number of challenges to defence healthcare during the last 12 months. And indeed, there will be an enduring impact, both as a direct result of dealing with this pandemic, but also in the recovery and rehabilitation of personnel and its services. However, what I don't intend to do today is dwell on those. But what I've done is spent some time reflecting on the experiences of the last 18 months or so as I've formed my thoughts for today. Just to be aware, I am on a phone today due to IT connectivity problems from the MOD, so I will be asking the team to move my slides on. So next slide, please. So as you see in terms of those pictures there, that is the Defence Medical Rehabilitation Centre at Stamford Hall. So when the pandemic came into play, I was commanding and running the Defence Medical Rehabilitation Centre at Stamford Hall. So I experienced at first hand the challenge of adapting service delivery. The challenge was striking the right balance of essential care delivery and patient and staff safety whilst the COVID-19 picture was evolving. As well as adapting clinical services for rehab, we were also scoping and planning options to support Defence, which included activities such as repurposing some of the clinical areas to care for any patients which contracted COVID-19. And under the clinical director and his team, we also undertook the rapid development of a post-COVID rehabilitation course. In the February, I was notified I'd been selected for promotion, and they were very keen to move me out into my new job as the Defence Regulator. The job was actually gapped at the time, but I stood my ground at Stamford Hall, and I didn't move on to post until August. So I moved into the job as head of Defence Medical Services Regulator in August. And really what I felt this gave me coming into that team was to able to approach this new role with the lens of recent experience running DMRC Stamford Hall, with full awareness of the challenges and constant changing nature of the pandemic. The entirety of the Defence Medical Service has been an area of defence that's been at the forefront of the response to COVID-19, both internally and in terms of its support to the United Kingdom. We saw a collaborative effort between the NHS and armed forces, which was effective and inspiring. Healthcare has had to adapt, and change has been accelerated, with the introduction of new and innovative services, many of which are now delivered by digital means. So I had to very much reset myself from focus of delivery to a focus of system safety. So very much poacher turned gamekeeper. So what I hope to do today is share some of my personal thoughts about managing healthcare in a crisis, and what you may need to consider as nurse leaders as pandemic impacts remain and we enter the next phase into what I am calling the new normal. While I'm speaking, I'd like you to think about an element of change that you've either driven, been forced to make, or had to adapt to as a result of the pandemic. I'm sure you all have a huge list, as I did as I was putting this together. Next slide, please. So there's three themes I want to talk to you, want you to think about today, and we'll sort of form the conversation as I talk for the next sort of 20 minutes or so. And that's about agile change, when temporary change becomes permanent, and when adapting to the new normal and what that might look like. I attempt for this session to be one to make you think, to enable you to reflect. And as Denise said, I'll leave some time for some questions and discussion at the end. Next slide, please. There's a number of risks with developing speed at change, especially, we all experience that advice was changing so rapidly. If I reflect on my time at Stamford Hall, the infection prevention control team came into my office sometimes 3 or 4 times a day, saying the advice had changed. They'd just be pushing information out, and it was a struggle to keep up with the information. I'm sure you all utterly experienced that in the same way. We also saw the NHS in particular, the need for critical care beds, which outstripped demand and drove the main effort. What I will say is, though, what I witnessed from the NHS and the broader healthcare services was real and perceived barriers to change were overcome. Huge changes were implemented by the NHS in weeks rather than years. I think we've all aspired to see transformation, aspired to see change, and so many things take so long. And I think the one thing that we've seen in this period is, agile change can happen. It's not without its challenges, as we'll discuss. But I think some of the pictures that I've put up there really reflect the things where we've seen huge changes happen at speed. The Excel centres going up at the speed they did, the rapid evolution and development of the COVID vaccine, the hands face space piece I put in there really to demonstrate that speed of changing in messaging. And again, we've spoken about the challenges of maintaining the different layers of PPE advice that came through, and again the clinical changes that had to be adapted, particularly to cope with that the ICU challenge, which was everything from equipment to people to capacity. Next slide, please. So I've picked this moment from Frozen. I'm not going to sing it, don't worry. But we found ourselves very much in the space. We're entering it into the unknown. As a result, all organisations had to go into crisis management. As I've mentioned already, the NHS had to adapt to change quicker than at any time it had seen in its history. Nightingale hospitals were set up in a matter of days. Services reduce face-to-face activity and will run virtually using digital technology. There is rapid upskilling of staff at scale. Many staff adapted their roles in order to help where the demand was greatest. Respiratory wards and theatres were repurposed to support ventilated patients. When the dust settles, the NHS will have changed beyond recognition and can now not return to business as usual, but it needs to reset to a new normal. But as I've already mentioned, I think the NHS should also realise and have confidence that it can be agile and can be adaptive, and change doesn't need to take years. Next slide, please. So what I didn't want to do today was to give you lots of theories and models of change. I want to leave time for today to very much be about reflection and thought, and to enable some time for conversation. But in terms of rapid change, the Plan, Do, Check, Act model, or you may refer to it as the Plan, Do, Study, Act model, the PDSA model, is a model that can be used effectively to test change and scale rapidly. Many of you may have seen this used in quality improvement methodology. Coming from a military background, planning and management of change is something that's very much built into our DNA, I suppose. Denise talked about me going to the Advanced Command and Staff College, and very much the basis of a lot of that work is about operational military planning and how you conduct planning. There is a convoluted process. It goes through a 7-step process. And I think what I found, and one of my sort of personal experiences from COVID, was the speed at which I had to implement some of the change. You know, the 3 or 4 times a day I was getting pulled into COVID meetings by my higher headquarters to really say, look at this, you know, what have you done about this? And, you know, very rapidly realised that following a 7-step estimate process and coming up with a comprehensive plan was just not the space that you could operate in. I had to move into something that was more agile. And so using something like the Plan, Do, Act, Check model is, you know, use a very simple planning process where you can understand where you are and when you need to get to. Make those changes at speed. But the key, and one of the keys to both, you know, coming onto the sort of the safety space and the understanding whether those changes you've made are effective, is the importance of doing the monitor and improvement. So, as I say, approaches to the improvement therefore offer a valuable way of dealing with complex problems, even in pressurised situations, and is a good methodology for rapid and agile change, particularly in the adaptation of clinical services, where you can see your changes taking effect rapidly and see and monitor what effect those changes are having. And I think there's a really important piece here, and it comes into the safety space. It's understanding that, you know, certainly for me, my priorities, and I made it really clear to all of my staff that my priorities were patient safety and staff safety. And if somebody saw something that was unsafe, there's a stop to make sure it was addressed at the time. We obviously saw, again, within the adaptations that happened to cope with the COVID crisis, regulation changing, for example, in relation to the use of student nurses. And the regulation changing in terms of those safety thresholds is something that raises huge concern with people, because are we suddenly accepting a lower standard? But what I would just ask you to reflect on, and where I use my military experience to kind of just take my breath and think about things, is in defence and in the military, we quite often face situations where we may be overwhelmed, and it's no different from a major incident policies and protocols that you will have within your own working areas. And then there's that point where services or systems may be overwhelmed, and it's in that space where risk starts to have to be undertaken. And the key in terms of risk is making sure it is as low as risk as possible, and then doing what you can to mitigate that, but recognising it is an incredibly important part of this process. Next slide, please. So I like this slide because even when you have time to a plan, you have that expectation of this nice, small, smooth journey. But in reality, we know that doesn't happen. You may face, I think that's meant to be a shark, but it looks more like a fish. But we all know you have mountains to climb, you have rivers to overcome, and you can find yourself stood at the top of a mountain screaming, no, How do I get down? Where do I go next? So I think it's important to remember and not to ever beat ourselves up that even when we have a smooth path to planning, it doesn't go according to plan. We all like to plan for change. Well, we might not like to, but that's reality. Transformation and constant transformation are themes of all our organisations. But as I think I said at the start, change can be incredibly slow, and change is often not agile enough to readjust. We all know change is challenging. As I've said, even when change is carefully planned for and the theories of change are followed, the journey to change is never easy. Agile change was what was required to manage a pandemic, and we had to learn on our feet, fighting the closest crocodile to the canoe. Next slide, please. You probably can't read that slide in detail, and I don't think it really matters, but I found this slide about risk assessment, which I really like, which sort of goes from the unacceptable level of safety, which means you go into a cage with a lion to feed the lion. The likely outcome is that the lion's going to eat you. And as you go in with some PPE, the lion might try and eat you, might not kill you, but you might come out with serious injuries. The next stage is that, you kind of, dip your hand in, still a risk. The next stage is having a completely closed environment to provide the lion with its food so that you and the lion don't come into contact. So when change is accelerating at speed, or there are multiple changes that have to take place, there's going to be codependencies that come as a result of that. So active risk management is essential, or there's real chance there may not be a risk control measure in place, or that a risk control could fail. In crisis, the reality is that risks that are not normally tolerated, for example, the reduction in patients' nurse to patient ratios or staff working in unfamiliar environments, are accepted due to the system being overwhelmed and having to deliver its best effort. It still, however, remains essential to ensure that those risks are both understood and mitigated. So how do you reduce risks and errors of new staff in an unfamiliar environment, for example? Measures such as putting an prescribed induction in for all staff. If we use human factors principles, putting in simple tick lists so that staff unfamiliar to the environment can check a bed and check that the equipment is safely set up in terms of that bed. Ensuring that written standard operating procedures are put in place, and ensuring staff are supported and can speak up. And I'll touch on that point again as we go through. And then when considering the introduction of new equipment, what's required before it's brought into use? Have all staff been trained on it? Do all staff know how to check it? I reflect on all of those as examples that I've seen since I've been in the regulator's post, where we've seen incident reporting reflect on things that have happened through the COVID period, and noting that actually there are fairly simple measures that can be put in place to reduce the risk of change that has happened at speed. And that's where the PDSA cycle is a useful metric to go back to check, to make sure you make any changes that are required. But once you've made those changes, don't stop at that point. If you've put in a tick list for bed equipment, make sure you audit that, make sure that any changes that people feel that need to be made. I think the key is that change and rapid change is no different. It will continue to evolve, and the key is to make sure that you keep on top of that, taking the time to just pause and check that processes are embedded as they need to be. Next slide, please. What I just wanted to do now is just from my perspective, I was reflecting back on where I was in terms of managing sort of the COVID crisis firsthand at the tactical level versus those things that I've seen as the regulator during my sort of 8 months in role. Is be clear about your priorities and communicate them. So my priorities were clear. They were patient and staff safety. And I made it very clear to my staff that if anybody had concerns at any point about patient and staff safety, they raised them. Flexibility and adaptability are key to success and were key for me in terms of achieving the change that I had to change in terms of adapting clinical services. Communication. Communication was essential, frequent listening and speaking. I did a lot of speaking, I did a lot of updating to my staff, but it was also essential that I listened as a leader, because it's very easy to sit, I don't want to say sit in ivory tower because that's really bad language, but, you know, sit in your office dealing with some of these difficult situations, think that the information is flowing down, and then suddenly realise you're not communicating it effectively enough, and neither are you listening to the information that's coming back. I don't want to talk about sort of how we've had to work differently in COVID, but I found in terms of reducing my presence out on the clinical floor to make sure we could deliver a safer environment as possible meant that you know, losing that face-to-face contact is, you have to learn to communicate in a different way, and it's certainly something that I've learned a lot about myself about in the last sort of year or so. Reevaluate and assess, and then don't forget to look after yourself. You can't look after others if you're running on empty, and don't be afraid to open up about how you're feeling. So what I thought is to say, I just share some of those thoughts now, and this might help us to reflect in some of the conversation shortly. So next slide, please. So what I want to do now is just talk a little bit about managing and challenging the new normal. So this quote by Donald Rumsfeld is one we rather love in the military. There are known knowns. There are things we know we know. We also know there are known unknowns. That is to say, we know there are some things we do not know, but they're also unknown unknowns. The ones we don't know, we don't know. So the military loves planning, as I'd already said. It loves developing multiple contingency plans to deal with and anticipate the possible and the expected. In defence, we do something called red teaming. So someone always plays the enemy. You can often guess the enemy's most likely response and its most dangerous response, but you then can still face an unknown unknown. The enemy still has a vote, and the enemy still has a voice. In our situation, we've often heard COVID referred to as the enemy, and you can predict some of its responses, but not predict all of it. And that's when you have to think on your feet. Next slide, please. So what I just wanted to do is remind you of the plan, do, act, check. Change requires proportionate measures to confidently improve systems and outcomes. Measurement can be simplified, being simplified by using routine collected data available to teams and allows interrogation and use. So the sort of data that's already available in terms of that gives a good indication of safety and gives a good indication of quality of care is patients' feedback, staff feedback, instant reporting, clinical outcomes. And the opportunities for leaders to ensure that the use of improvement tools and approaches used during a crisis help to embed improvement as a strategy for tackling the most complex future challenges. Again, within Defence, we have within the Defence Safety Agency, we've got a policy, and again, this might be something we want to touch on about, which is about organisational safety assessments. So when significant organisational change is taking place in Defence, policy requires whatever area of the organisation to undertake an organisational safety assessment. Without going into sort of the detail of how that process is done, the point of undertaking an organisational safety assessment is understanding and benchmarking where you're coming from and where you're going to. Clearly, when you're doing rapid changes you had to do within this situation, you don't have time to necessarily undertake that initial assessment. But what we are recommending our organisation does now is does a reflective look at those changes that it's made and set that baseline assessment. So what was the standard that was being achieved by the old service? What were the safety risks that were being carried by the old service? How do we mitigate those? Then what you do is you baseline where you've got to within your new service and understand if that change has had any impact on those baselining. So, for example, if you can see your change has demonstrated a reduction in safety, you can quantify that by using the review methodologies that you've gained through your monitoring information to really understand whether your new service has delivered service improvement, whether it is safe as your old service, or actually you are still carrying risk. And I know from talking to Denise, that sort of shift from, that crisis activity to now the new normal, where services that have changed are remaining in that change space causes some anxiety. And for me, it's very much about the understanding piece is essential. So next slide, please. So just reflecting on Donald's quote. So do an estimate, understanding is key. So as I've said, understanding where you came from to where you've got to is essential to know what impacts those changes have had on your organisation. So what are your known knowns? Your known knowns are those predictable scenarios that generate the information you can. And what have you learned? So I say review is essential in terms of what have you learned from those changes? What are your known unknowns? What assumptions can you make? How can you handle your known unknowns and be prepared for them? What are the volume and scale for another COVID response? Again, what have you learned? Can you have contingency plans ready to go, or will you maintain contingent capability at readiness? So that's the element of bringing COVID crisis management really into the new normal. I think we all recognise that just when we think we're coming out the other side, we're going back into a situation where we have new variants, where we see hospital admissions rising again, and we really don't know what the impact is going to be over the course of the next few months. There's a lot for health services to be incredibly proud of that they've challenged and delivered with in the previous 12 months. But as we come out of the pandemic, systems and services need to evaluate how they move out of the pandemic to deal with change services and building that backlog of routine work back into business. Does the system understand the current level of unmet need? The organisation needs to take a breath, and healthcare systems are going to feel the immediate and long-term impact of the pandemic for some time to come. What are the additional impacts on the system from COVID, post-COVID syndrome, additional seasonal vaccination programmes, the long-term changes to standard PPE? And how can the system continue to improve as it recovers, and can it continue to improve as it recovers? During the acute phase of the pandemic, considerable changes to service provision have taken place, and we need to consider whether they've been helpful and should continue, and which aspects of routine service delivery need to be reinstated. Where service changes have been undertaken as part of the COVID response, is there evidence that supports this as good practice to continue? Building up a picture of quality and safety is essential. Monitoring, improving, replanning. The bulk of services suspended cannot just be switched onto their pre-COVID state of February 2020, but moving out of an immediate crisis and embracing the required ongoing, often uncomfortable reality of ongoing responsive change, adaptation, agility and resilience is the new normal. Difficult choices still remain for professionals across health and care systems. So what have you done or could do to evidence positive or negative impact? Has there been unintended consequences of change that should now be considered? Were the risks associated with change understood? Does risk still exist? Adapting to crisis should not normalise acceptable risks as tolerable. So I'll leave you with another open question here is, can you think of a situation where you've raised concerns and they've been ignored? Next slide, please. So I just put some thoughts down here about, and again, this is in my current post where I've been engaging with the Defence Medical Services headquarters, and really in terms of understanding what do you need from your organisation and what do you need from your own leadership to help you not just get through this next period, but to thrive. Safety culture. Safety culture is incredibly important. It needs to have no blame central to it. Where the risks associated with change are understood, does risk still exist? As I've said, adapting to a crisis should not normalise unacceptable risk as tolerable. Psychological safety. Feeling safe in the environment you're working in, both physically and mentally, is incredibly important and has known linkages to safe patient care delivery. And again, organisation ensuring it delivers an environment of a psychological safety for its staff is part of that safety culture. Organisational learning. What can be learnt to inform the now and to prepare for the next crisis? A healthy and resilient workforce. How can you build resilience into your organisation? What's the strategy for looking after and building the workforce? Involve patients. We all know, again, that patient voice is an incredibly important one. Have we got enough information from our patients to understand whether the new services and the adaptation to services are going to deliver safe and effective care for them? And then resource. You know, we all need resource. Do we know what the new resource picture looks like? We saw a lot of financial support coming into the organisation to manage the COVID response. How is the resource going to reflect what the organisation needs going forward? And then before we go on to our questions, just my last slide, please. As a safety regulator, it would not surprise you that I'm finishing on a safety point. So before presenting today, I Googled just to have a look and see what popped out in terms of Google, in terms of change in NHS Wales. And this newspaper article is what came into my Google window about Wales NHS doctors bullied for raising safety fears. Safety through learning requires a transparent culture that enables people to speak up and share learning and improvement opportunities. Staff will go above and beyond, but they need to have their voices heard so they feel safe both physically and emotionally. Clearly, this is a news story and I don't have the fact, but it's a reminder that to succeed in the next stages of the new normal, where you may again be required to step into the unknown, that you understand what risks you may have, you raise concerns, and you encourage your staff to raise them. Healthcare has a way to go until the right safety culture is embedded, and capturing lessons from this period are essential to help deal with the next pandemic and indeed the next stages of this one. Next slide, please. So what I've tried to do is just to give some food for thought here in terms of the areas I've covered. And now I'm hoping time-wise I've left plenty of time for us to sort of have some questions. So thank you very much.
Thank you, Ali. That was just so interesting, and there was just so much in there that I'm sure people have got massive amount of questions. But the way it was framed, and certainly by speaking to some of our members in the Royal College of Nursing, you've touched on so much that people are concerned about going forward, really. And there was almost small plans within it that people could grab and actually use. So thank you so much. It was extremely inspirational. I'm going to introduce now Nicola Davis-Job. I'm sure she's going to pop on her camera because she's going to be the question master. But I am going to take Chair's license and take a question, if I may. That issue of blame, I think it's a very interesting one. It's one that's very interesting when we're not in a COVID crisis. But as you said, the agility and the need to change very quickly has caused quite a lot of concern to some of the professionals I've spoken to. So with your regulator's hat on, what do you think is the biggest risk to patient safety as a result of that rapid and agile change?
Thank you, Denise. Yeah. And I think you know, the blame culture. I would just touch on that first. So for me, coming into the Defence Safety Authority has given me a real eye opener, because the Defence Safety Authority historically has grown out of the Aviation Authority, and you'll all be familiar with the sort of development that took place in the aviation world to get them into a safe place from a safety perspective. And you know, I am learning and trying to suck as much information and knowledge I can from the other safety regulators to try and move defence healthcare safety into the same sort of space. And I think the first point is it takes a long time. So I think in terms of saying, you know, the question about what do I think is the biggest risk to patient safety, I've got a couple of things really. I think making assumptions is essential, but also dangerous. And I think this relates to, you know, this sort of agile change. You must conduct your own audit and assurance activity, confirm those assumptions. Assuming a process will work because it works somewhere else is a good starting point, but you must check it. You may experience different learning. And my next point of that is, the second point is learning. Healthcare organisations must be learning organisations. And the reason I reflect on that is, again, in relation to my own experience I've seen coming into the role as a regulator. And if I give you an example of where I've seen it in Defence, Defence was already on a transformation programme for its defence primary healthcare. But as a result of COVID, it undertook some of its rapid transformation at speed. And two of those things were bringing in eConsult, which is the general practice triage tool that many of you be familiar with. And the other one was Attend Anywhere, which is a video conferencing tool. They brought those into service and didn't conduct any assurance on them. And when I was seeing patient safety incidents coming out as a result of it, most of which were pretty simple fixes, to be fair, the lack of assurance on the system meant that these things happened. And my point was going back, you need to do assurance on the system, you need to audit its use now you're using it. And this sweeping assumption had been made, well, they've been using the NHS and it works fine. And one other area where we saw something as well was a new piece of equipment that had been acquired by Defence. It was ventilators, was brought and used in the Nightingale hospitals. Now, that ventilator, it went through its full safety process for use within a Defence environment. But when that ventilator was put into the back of an NHS ambulance and that ventilator failed, the reset button wasn't accessible because that assessment hadn't been made. So there was this assumption that if it worked okay in a military environment, it would be fine in a civilian environment. So for me, it's the assumptions piece, and making sure that you conduct your own assessments is really important. I think there's other things, but yeah. I think just in terms of enabling any sort of broader questions and discussions to go on, I'll probably just sort of make that as my sort of pitch in terms of that question.
That's excellent, thank you. Nicola, you've got the questions coming in from our participants today, so I'm going to hand over to you now to ask the questions to Commodore Hofman, please. Thank you.
Thank you, Denise. Thank you, Ali. I'd like to ask you something that isn't on the list at the minute, though. I want to ask you, who or what inspires you and motivates you to keep going?
So for me, so honestly, and this is something I've reflected on quite a lot of time in my career, because for me, there's only 5 female Commodores in the Navy, and sort of where do I draw my inspiration from to sort of drive this? I would say it's my patients. I honestly think it's that. And if I use examples where I have seen patients just sort of overcome their adversity and their injuries, running a field hospital in Afghanistan and seeing the trauma that I've seen, and most recently my job at Stamford Hall, it's very much making sure that the environment and the care we provide for our patients is the best it possibly can be. So I think my inspiration comes from my patients.
Thank you. I can really relate to that as well, being a neuro nurse and seeing patients who you think, are just not going to make it, just have a sense of purpose and life afterwards. And I can relate to that, having to speak to patients, going to the field hospital. The first 2 people who went to the field hospital in Carmarthen, and I was charged with asking them to go without using the word field hospital or using the word leisure centre, which was really difficult. But you're right, speaking to them the next morning, they were really pleased that they had gone, they had slept well, they had eaten properly, they had rested. And as long as there was no delay in the discharge, they really didn't mind at all, because everybody was welcoming and because people were listening and people had the time. So that's enough of me. I'm now just going to ask you the questions coming in. So the first one, how can you communicate well with teams when the message is constantly changing? And I'm thinking here they must mean at the start of the COVID pandemic, when the message was changing constantly?
So I think, as I alluded to earlier, it's something I really struggled with, and I did a lot of sort of testing and adjusting about the communication. So one of the things I really pinned down for my team was how they wanted me to communicate. How was it best for me to get those messages across to them? I had, you know, a lot of staff working remotely. I had staff, as I say, working in PPE and clinical environments, and getting communication through and making sure a consistent message was delivered was hugely challenging. And I recognise, as I said in my presentation, the PPE message was a real challenge. And I think, you know, one of the important, and I spoke about the importance of communication. I think one of that is being honest.
Yeah.
And being clear about, you know, when we were resending out an update of the policy and going, oh, sorry, it's changed 3 times today. You know, I think it's recognising why those changes have taken place. And I think when people can understand why it's happened, and for me, that's really important, not just say this has changed, why, because without the why, it's very difficult people to assimilate and to sort of do that. So I think for me, it's how you communicate with them. So, you know, is the right way of having a text message alert? Is it by, you know, having verbal conversations? Is it by newsletters? What is it? So in terms of our battle rhythm, so we call it a diary, we call battle rhythm in defence because it sounds really warring. But we had, you know, daily COVID updates, which I had with the team. And, you know, it was very much cascade information flow in terms of that. We would call operational planning meetings as required. So I think it's being able to be adaptable and agile. And I also think it's honest about why that information has changed. And the frustration that you know, my staff had frequently, and one of the frustrations that I had is we had a lot of, if I go back to my sort of initial stages at Stamford Hall, we had a lot of information coming in from a lot of different channels, but nobody really gave the direction about how we implemented that change. So it's very much left to me on the ground to drive the information flow and the change within the headquarters down through the organisation. But I quite often find that a message would come back, somebody else had heard something else through the grapevine. So again, it was making it very clear to people which information source was the source that they needed to listen to. And we found that Defence would eventually put something in writing, you know, much later than we needed it to be. So again, it was having the confidence to say, you know, I'm making this decision, we're holding by this decision, and you know, follow the last order unless you hear otherwise. So I don't think I have any real true answer for it, other than just keep thinking about it and listen to people. You know, and if the feedback that you get is that messaging isn't going through, you've got to find another way of doing it. So it's a challenge, and I don't think there's a right answer ultimately.
I think from what you've said about being honest and authentic and telling your team, I'm sorry I've told you this and it's slightly changed, and just be honest, I think is the right thing. I have a question here from Tina Donnelly, who you know very well.
Hi, Tina.
It's a no blame culture is difficult given the public perception of their experience, especially when they've lost a loved one. How do you think communication processes should be planned to help?
What, with patients and their families?
And the no blame culture.
Yeah, so a no blame culture is a difficult one, and as I've said, I think it's and culture is the important word here, because we have accountable professionals, you know, sort of holding accountability and ownership of you know, mistakes, errors. You know, is kind of a culture thing we've got into. But you know, to err is to be human. People make mistakes, and you know, there's the point of the no blame culture is all about learning. It's all about demonstrating learning, so that it doesn't happen again. Unfortunately, when there's very significant incidents, and there tends to be, you know, there's somebody at the end of it, you know, whether it's through litigation means or or whatever, then, you know, sometimes, you know, correction of individuals' practice or being held for accountable practice is the right one. But the point of the no blame culture is that we have an open culture where people welcome being told. You know, we need a situation where people welcome being told that they can do what they're doing differently and better. And again, I think this comes down to the essence of a safety culture in the organisation. I've had some interesting conversations with people where I would say that they confuse risk with safety. And they'll say, well, I understand the risk and we've got risk mitigations in, and I'll say, but it's still not safe. And therefore, you shouldn't be doing it. And, you know, particularly within in defence, you know, a lot of what is done in defence is done with, you know, making risks as low as risk as possible. A LARP, we use the term LARP in, you know, a lot of business. And what I see within the healthcare space is it's making sure that the organisation that's owning the activity, which is defence and healthcare, are providing effectively the mitigation to that situation, because they're providing the treatment should people get injured. But as I keep saying to the professionals within, you know, Defence Medical Services, that doesn't mean that an unsafe risk is accepted. And, you know, if a commander is trying to deliver that, then that information needs to be pushed up. So I think it's, you know, the only way you can change a no blame culture, and the only way you can create a good safety culture, is everybody believing in it, and everybody, you know, recognising that to speak up is the right one. But also, a lot of people are constrained by their own organisations, and we saw that with that newspaper article as an example. There are other avenues to take things to, and again, I think you know, if people actually feel that they are going to be bullied or lose their jobs over speaking up, because somebody worries that blame is going to be attributed, it's just a wrong space for you to be in. And I can recommend a really good book to people, Black Box Thinking. And the Matthew Said book. And Matthew Said actually spoke at one of our defence events recently. You know, and he talks about, you know, and we use the aircraft industry as an example of somewhere that has got rid of a no blame culture and has a positive organisational learning culture. And it took them, you know, a good 10+ years to get there. And it is taking healthcare longer. But I see, you know, within, and apologies, because I know Wales sits in a different space with this because because of your devolved position. But NHS England 2019, so last year, released their patient safety strategy. Health Education England have now released their syllabus for that. So I think the key for here is education and educating the workforce. In terms of the piece that Tina talks about there is an education for patients required here as well, because, you know, patients will look for blame, but I think that's the same with any environment and anywhere. People want somebody to be accountable and to hold it, but organisations need to make sure they're accountable and they support their personnel and they support learning in their organisation to make sure that we can drive this.
Yes, I think then what you're saying is the duty of candour, and I think that most people would want the death of their loved one not to be in vain, that the lessons would be learned and it wouldn't happen to somebody else.
Yeah, absolutely. And as you say, if duty of candour is delivered early and in the right way, then that should give that, you know, family the understanding, you know, that it isn't acceptable and it's being dealt with.
Okay, we have time for maybe 2 questions. You mentioned some of your leadership lessons. What attributes as a leader are important, you think, to manage change successfully? So would you give a top 5 maybe?
Okay, yeah, I mean, I think I've already mentioned one, humility. You need to admit when you're wrong. You're not always going to get it right. And I think what I would use here, and as I would try and pick 5 that I believe are attributes that, you know, that I've witnessed in my practice. So humility. I think we've all witnessed situations where, you know, change hasn't worked, you've got to make sure that if it's not working, you've got to stop and take a new direction. Authenticity. Don't try and be someone else. You need to be your true self. People need to see, you not try and act like somebody. Compassion. You need to show your care. Don't just say it, you need to be it. Communication skills. We've spoken already about the importance of communication. So for me, communications skills are really important as well. And I think the other one is being able to work collegiately. I think if we look at change theory again, I mean, all of those you probably will recognise within change theory somewhere. But again, if you don't bring people along with you in terms of change, then it's not going to work.
Yeah, I think that's the followership that has to go with leadership. Finally, then, how can we succession plan for the future? I'm thinking specifically nursing.
Yeah, so for me, that's a really good sort of succession plan is a good point, because in defence, and Denise mentioned on my CV, we move jobs frequently, and so succession planning is poor. And within my area, it's not taken control of the employing organisation. So I've gone into the Defence Safety Authority. My selection into this post was done by a tri-service senior appointments board, not by the Defence Safety Authority. But what I will say as well is, having the approach that Defence has, it does allow for some risks to be taken in talent management, and also avoid some groupthink because of the way the selection process is done. So succession planning can result in more of the same, and risks sort of reducing diverse thought as well, because we need disruptors, right, don't we? We all need disruptors in our organisation. But I think in terms of succession planning, I would say, in terms of leaders, every leader is responsible for those that they work with and those they manage. I have a very firm sort of analogy I use, which is about climbing a ladder. I've got up the rungs of the ladder, but if I don't drop that ladder down and let other people climb up it, you're just risking this massive vacuum, or actually they can't even reach the ladder in the first place. So I think there's that individual leadership responsibility which drives into succession planning. We're all responsible for building the leaders of the future, and and we have to be supportive to individuals, because you will see people that you develop rise above you, and it's about recognizing that actually that is right for the organization in terms of that talent piece. I think for me, a good way to sort of support succession planning and development is mentoring, coaching. I think those are strategies are really good ones. And I think I think it depends what jobs you're thinking about. I think in terms of nursing profession as a whole, and I think this sort of dips into workforce strategy. How do we succession plan for the profession to make sure the profession can be a resilient profession, a profession that can continue to develop and really flourish despite. I think we'll see two responses from COVID. There's going to be the flourishing piece, where people have been exposed perhaps to the nursing profession, that think that's great, I want to give some of that. And then there's the other side of those that are in the profession that are going to say, I've had enough of this has been too hard, I don't want to carry on. I don't feel comfortable working in a position where I can't give everything I want to give to my patients, and it's moved too far away from where it was. So I think in terms of succession planning for the future has to start at how we generate the workforce of the future. And there's a lot in there. I've already mentioned some things about embedding that safety culture right at the start. It's about making sure the education processes, the finance, the resources. I think it's probably a week session in itself just talking about succession planning and how you succession plan. But I think if I was to say two key things, it's everybody's responsibility to support recognised talent and to push that ladder down so people can climb up it, and if need be overtake you on it and step to the next run. And really sort of this links to everything we've been talking about in change. It's about understanding the where we're going to. You know, do we need to make sure that our leaders of the future have got specific skills in terms of who needs to succeed various roles, whether that be in change management, whether it be, you know, we talked about, you know, sort of leadership skills, and for me, I think I have to be an adaptive leader, and I think we all have to be adaptive leaders. You know, sometimes I talked about, you know, being a compassionate leader, being an authentic leader. Sometimes I have to be that, you know, the leader that says you are to do this.
Yes.
And certainly in terms of some of my health and safety priorities, I talked about patient safety, staff safety being my essentials. I had to say you are to. And I had a very clear policy at Stamford Hall that if people breached the COVID you know, guidelines, then they would be held to account for that. That, you know, people knew exactly where they stood. So there's sometimes is that need to you know, have leaders for that, and then you need the leaders you know, to manage change in a different way, and not everybody can be everything. So when you're looking at succession planning and you're building a leadership team, you probably need to look at a blend of attributes. It comes down to that sort of leadership diversity piece, that if you just grow more of you and more of the same, then you don't enable that diversity of thought. And that comes back down to my point of making sure you've kind of got those disruptors. You've got people who give the challenge to the organisation.
Thank you so much. I've so enjoyed your session. I need to hand back to Denise just for our final goodbye, but thank you so much.
Thank you.
Yes, thank you, Nicola. Commander Hofman, I just have to say a huge thank you. I thought the title was quite broad, from crisis to business as usual. I'm going to change that from crisis to the new norm after hearing the inspirational way you spoke today. And I absolutely, the breadth of what you've covered in an hour, I'd love to have you on here for 2 or 3. So thank you so much, Ali. It's been it has been inspirational, and I'm sure there's huge amounts of things that people will be picking up on, and your ideas for books and stuff like that. For me, organizational assessments, fantastic. Let's do those things before we need to do them. From a regulator point of view, it's fantastic to hear that, you know, risk and safety aren't the same, and sometimes people shouldn't be bashing themselves up about that. It's about that mitigation. But when you're really worried, you have to talk to somebody and tell somebody. I've so much enjoyed it. I'm having pings on my phone actually saying this is inspirational, brilliant, and I'm sure we've had comments on the chat as well. I know you have to go, so please go with our sincere thanks, and I'm sure we'll be asking you again sometime to come and visit Wales and talk about the fantastic career that you've had and the experience that you can share with us. So thank you so much for that. And I know you have to leave, so please, if you do have to leave, please leave.
Thank you, apologies, I've got a finance meeting.
Yeah, get those resources. Get those resources sorted.
Thank you very much for having me today. It's been lovely. Thank you.
Thank you very much. And I just want to say that for people on the call, there is a link to an evaluation, if you wouldn't mind doing that for us. That would be fantastic. And we've got one more Lunch and Learn episode, which is next week. And Nicola, I'm going to go to you because I haven't got the title here. I know it's about digital.
It's informatics and nursing, and we have Claire Bevan and Fran Beadle, who are currently heading up the WNCR, which is the Welsh Nursing Records programme, which is very exciting. We've spoken, it's been a long time coming, but it will transform patient care and the way that nurses document their patient care delivery. So really exciting.
Great. Well, I'm sure people will look forward to that, and please tune in next time. I'm hoping we can expand these Lunch and Learn. I think that they've been fantastic. Can I thank the team? I know that Will and Katie are on there, and Abigail, and to you, Nicola, and see you all next week. Thank you very, very much.